All right, guys, this is Dr. Ash again, and we are going to talk about some of our common anemias today. All right, so anemia is where we are going to get started here. So what is anemia? The definition of anemia by itself is there is not enough healthy red blood cells to carry that oxygen to the cell. So this actually goes very well with perfusion, although a lot of colleges put it kind of in the cellular part because we are going to talk about specific cells as it relates to anemia. And so basically what happens is these red blood cells get produced in the bone marrow, and the bone marrow actually requires certain nutrients like B12 and folic acid and iron to kind of get these red blood cells formed, particularly hemoglobin. And so there are three main processes by which a patient would develop anemia. One, your body doesn't make enough, and we're going to talk about these individually. Number two, your body is bleeding for some reason. And then number three, at some point or, with some sort of something going on, the body destroys the red blood cells a little bit faster than what they can be made or as the body can make them and use them appropriately. And so we're going to talk a little bit more about these three main processes just so you can kind of wrap your head around it. All right, so we don't make enough. That's the first thing. So this can be related to iron, B12, folate, or B6, or some sort of disease process. And so we're looking at things like iron deficiency anemia, B12 deficiency, folate, etc. The disease processes that can lead to this might be cancer, HIV/AIDS patients, kidney disease because the erythropoietin is excreted by the kidneys and we need erythropoietin in order to stimulate red blood cells. There could be some sort of disease of the bone marrow specifically. And then I add Crohn's in here, but really we can add Crohn's, ulcerative colitis, celiac disease, gastric surgeries, anything that causes a malabsorption state. So we can't absorb through our GI tract for whatever reason, and therefore we can't make enough red blood cells because we're not getting enough iron either through our diet or our gut is not absorbing it. Bleeding, okay, this is the second most common reason why we have anemia. And so bleeding can either be post-surgical, right? We've had surgery, it was extensive, they had a lot of blood loss, etc. Therefore, we have GI bleeding. Also, what puts us at risk for bleeding and having anemia would be if our PTT levels or our INR levels, which is international normalized ratio, if they are elevated. And so I've put the normals in parentheses here. So a PTT, 30 to 40 seconds, anything greater than that. An INR, anything greater than 1.1. Okay, and I say we're not on meds because there are certain states, as you learned in perfusion, or if you haven't gotten there yet, the perfusion we talked about, heparin is going to make our PTT level go up. Warfarin or Coumadin is going to make our INR level go up. So these are elevated, but we're not on those medications. That puts us at risk for bleeding. The other thing that puts us at risk for bleeding is thrombocytopenia, and that's when our platelet levels are super duper low, okay? But also with this bleeding, I put an asterisk down here because this is a big NCLEX thing, all right? Not only is it big on nursing tests, it's also big on the NCLEX, and that is understanding that a GI bleed, an elevated PT-INR, and a low platelet level, these are going to be across the board your safety risk. These patients are on bleeding precautions. They are non-skid footwear with assist to ambulation, electric razors only. For repositioning, we use a lift sheet because we don't want any shearing of the skin that would cause some epidermal bleeding, soft bristle toothbrush because we don't want the gums to bleed. So even though bleeding causes anemia, it also has a risk, an inherent safety risk factor that goes behind it that not only your nursing test, but also your NCLEX loves to ask you about. And then there's also, again, the rapid destruction of red blood cells. And that specifically is hemolytic anemia, which I promise we're going to talk about. So we have a couple of different risk factors that are associated with anemias. And so women tend to be a higher risk because of menses or periods. Also, they have typically lower iron intake or issues with iron. So women tend to be at higher risk. Infants to 2 years of age, so infants and toddlers, this is the highest level of growth. And so when that happens, sometimes they can't get enough intake to meet the demands of that high growth. The other piece to that is when they get weaned to solid foods, that body has a transition period of when it can start to absorb iron and nutrients like it should. So oftentimes in this situation, and I think I say it again a little bit later on, but just in case I don't, these would be your populations that you would add iron drops or iron fortified cereals like the rice cereal, oatmeals to the infant and toddler diet. Of course, our people over the age of 65, I feel like those are risk factors for any disease disorders, but over the age of 65, they tend to have a poor diet, poor intake, and they also have chronic disease processes that feed into their ability not only to absorb nutrients, but also to produce new red blood cells. Of course, when we're on blood thinners, because the blood thinners put us at higher risk for bleeding, therefore higher risk for anemia. Higher altitudes, there's low partial pressures of oxygen. So those that are in Colorado, that higher mountain altitudes tend to have a higher risk factor of anemia. And of course, malnutrition, we talked about this already. If I'm not getting enough nutrients in, of course, I can be deficient in multiple, especially the vitamins and the iron. And then, of course, again, the malabsorption syndromes, if you have Crohn's or celiac disease, if you've had gastric surgery, things of that nature, that's going to put you at risk for anemia. Okay. And let's see, common symptoms. Okay, so among all anemias, every single anemia, no matter which ones we talk about coming up, these are your common core symptoms. Tachycardia at rest. Why? Because the body senses there are not enough red blood cells and hemoglobin circulating, so the heart will speed up in an attempt to get that oxygen circulated to tissues. Fatigue, we're tired. When you don't have enough oxygen, you get tired. Pale, we don't have the ability to have a lot of color in our cheeks. Get very dizzy because of the low blood volume. Short of breath because your body needs that to work. And so the body gets very tired, very short of breath, hard to complete sentences. Okay, you may have a headache, feelings of being cold. And then there's also this pica craving. So a lot of people say, oh, you're craving ice, you must be anemic, which is true a lot of times, but technically it's a form of pica, which means you crave things that do not give nutrients. Ice does not give nutrients. So let's start out with iron deficiency anemia because it's the most common of the anemias. This is a lack of iron. Your bone marrow needs iron in order to produce hemoglobin for the red blood cells. And what we find is that the red blood cells tend to be, if you look at them under a microscope, they tend to be very small, so microcytic, and they also tend to be a pale red. Instead of that nice beefy deep red color, they are more of a pale red color. Causes of iron deficiency anemia can be pregnancy because, again, the blood volume is increased. Therefore, we have a diluted amount of iron. It could be from blood loss, menses, or a GI bleed. It could be through a GI ulcer. Bowel cancers will cause iron deficiency anemia because, again, that absorption is reduced. Any type of surgery, aspirin or NSAIDs are also a major cause of iron deficiency anemia. And so how do we treat it? Well, anytime you're looking at a nursing test, I want you to think least invasive first. And what can I control as a nurse? And so one of those things happens to be diet, which happens to be something you guys don't like, but that's okay. So iron-rich foods, I'm talking about the animal proteins, eggs, beef, meats, lentils, again, those iron-fortified cereals like cream of wheat or oatmeal, dried fruits like raisins and prunes, dark green leafy vegetables. We talked about avoiding them for our patients on warfarin or Coumadin, but we actually need these dark green leafy vegetables for several of these anemias. Now, I will go ahead and tell you that vitamin C actually assists in absorption. So we're looking for the citrusy kinds of things. This could be fruits or fruit juices, peppers, broccoli, tomatoes, melons, strawberries. I think most people think of orange juice as the major one. But however, we want to avoid milk and calcium, such as Tums or calcium carbonate, which is very common in the antacids, because that will actually block absorption of iron. So a couple of ways you can get iron supplementation is either going to be through a pill, an oral pill, or you can be given an IV infusion of iron, one or the other. Again, here's that 4 to 6 month age range where we're going to put them on iron drops, iron fortified cereals, and pureed meats. An ideal breakfast, like if I were looking through answer choices and I'm like, what is going to be the best for this patient that has iron deficiency anemia? Orange juice, because that's your vitamin C, eggs, because that's your animal protein, and raisin bread or toast, because that's your dried fruits. So those would be, or that would be kind of like the ideal breakfast for your iron deficiency anemia. The store. Vitamin-related anemias. All right, this has to do with your lack of B12 or folate. So we're doing B12 iron deficient, or sorry, B12 deficiency first. This is a lack of B12, again, either because of malabsorption or the immune system attacks what's called the intrinsic factor that sits in your stomach. And this is called pernicious anemia. And so B12 foods, again, we're going to start with the least invasive. That would be meat, dairy, soy, or fortified cereals. So you see a lot of these kind of coincide. Hopefully you see a connection here. Or you can have a oral B12 supplement, which doesn't really have any restrictions to it. Or for people who have more severe anemia, or for people who have that pernicious anemia where the intrinsic factor gets attacked, it may be more suitable to get IM injections. And those can start out as kind of weekly and then move to monthly. Other symptoms associated with B12. And so what I did was I gave you the blanket symptoms that you're going to see. So that tachycardia, pale, dizzy, short of breath, that doesn't change. But when we get to the specific anemias, some of them have very specific side effects, and B12 happens to be one of them because it includes neurological issues, numbness, tingling, weakness, confusion. So when you start thinking of vitamin B12 deficiency, I want you to start thinking of those neurological conditions. All right, we'll move on to folate, which is also known as B6. Again, this can be malabsorption. It could also be chronic alcohol use. And there are some anti-seizures like phenobarbital, carbamazepine that will actually cause a folate deficiency. Again, we're going to go least invasive first, which is folate-rich foods. Fruit juices, again, those dark green leafies, green peas, kidney beans, peanuts, breads, pasta, cereal, and rice. And of course, we know that folate, or should know that folate is quite important during pregnancy because that is what helps the neural tube actually fuse during pregnancy. So very important. All right, we have inflammatory anemias, which we're not going to go too much into detail just because, you know, some of the other anemias incorporate an inflammatory anemia, but this can be related to cancers, HIV, rheumatoid arthritis, kidney disease, or Crohn's. And typically how we treat this is we treat the underlying cause. So typically we're going to give a hormone injection of erythropoietin. Remember I told you earlier, erythropoietin is that nice little hormone that the kidneys are responsible for letting go of in order for the bone marrow to stimulate red blood cells. Sorry about that. Let me see if I can get the dog to be quiet. All right, so we'll get back into this. Let's see. The next one we have is aplastic anemia. Aplastic anemia is a deficiency where the body does not produce or it stops producing enough red blood cells. This is a type of anemia where all three formed blood cells are low. So red blood cells, white blood cells, and platelet counts are all super low. It is rare. It is life-threatening. Viral infections often prompt this to happen. So your body's doing fine, going along like it should, and then all of a sudden a viral infection attacks the cells, right? Because the virus needs host cells in order to replicate and thrive. And so therefore what's going to happen is this virus takes over the DNA and messes with the chemicals or hormones, enzymes, whatever that is responsible for producing red blood cells. Certain medications like antibiotics, rheumatoid arthritis medications, sometimes it's an autoimmune response. And if you haven't learned about autoimmune yet, autoimmune is basically where the body's own immune system attacks itself. And so oftentimes that can happen with our blood products as well. Or it could be an extensive toxic chemical exposure like pesticides, chemotherapy, radiation, etc. And so oftentimes how we treat this is we're going to give blood transfusions. There may be a bone marrow transplant, which actually requires a consent first. A bone marrow aspiration, which requires a consent form. Anything invasive requires consent to a point. Or they may choose to treat with bone marrow stimulants like filgrastim and epoetin alpha, and those would be subcutaneous injections. Additional symptoms that go along with aplastic anemia, again, those general symptoms apply, but then they also have frequent bleeding, bruising, infections, rash, and nosebleeds. And again, that's related to the decreased white blood cell count as well as the decrease in platelets. Actual diseases of the bone marrow, these would be things like leukemia and myelofibrosis. They actually affect how the bone marrow produces red blood cells. Typically, this is going to get treated with either chemotherapy or a bone marrow transplant. Our hemolytic anemias, this is where the red blood cells actually are destroyed faster than the body can replace them. And so what happens in this particular situation is they end up with a high reticulocyte count. And what is a reticulocyte? It is an immature red blood cell. And so the body never really gets the ability to mature this red blood cell because they need more in production. So they just kind of overproduce these immature red blood cells. Now, again, the normal is in parentheses, anything less than 2% on the reticulocyte count is normal. So anything higher than that, we're concerned with hemolytic anemia. And again, this could be a genetic defect or it could be developed as we age. And if it's developed as we age, it tends to be either triggered by medications or infections. So we have to be careful about that. Treatment, of course, we would avoid the medication if that's what's causing it. We would treat the infection if that's what's causing it. Or we may need an immunosuppressant, and this is particularly important if it is a genetic hemolytic anemia. The thing about this is it usually requires ongoing treatment, especially if it's genetic, right? If you're born with something, you can't just treat it once. You have to continually treat it over and over again. I do want to mention G6PD deficiency really quickly. This is glucose 6-phosphate dehydrogenase deficiency. And basically what that is it's a lack of glucose 6-phosphate dehydrogenase, so thus the name, lack of that G6PD. And the RBCs literally cannot function. They literally cannot function the way they are supposed to. And this is again triggered by infections, triggered by fava beans, and certain medications. And so that's kind of interesting, fava beans. It's not one that you hear of very often. Every time I hear fava beans, I think of Hannibal Lecter. But anyways, certain medications, this is going to be your key here. Okay, this is the one we're going to try to talk about. Test about. This is something we're going to try to test on. So medications would be sulfa-based medications. A lot of times those are your antibiotics. Bactrim would be one of those sulfa type medications. Quinolones, which again is a type of antibiotic. Antimalarials, which tend to have quinine in the name. NSAID, so aspirin, ibuprofen. Isosorbide, which is a cardiac medication. Vitamin C, vitamin K. Isoniazid, which is a tuberculosis medication. And then thiazide diuretics. Sickle cell anemia, we are not going to discuss here. We'll have a whole lecture on sickle cell anemia just because I try to keep these short and sweet, and sickle cell by itself is going to be like a whole conversation. All right, the last thing I want to mention here under the anemias is thalassemia. So thalassemia is actually a genetic disorder that causes specifically low hemoglobin. It's a mutation in the DNA sequence that actually makes hemoglobin. And it can be a deficit or a mutation in either an alpha chain or a beta chain, because hemoglobin have both. They have an alpha chain and a beta chain. It is highly common in our African American, Mediterranean, and Southeast Asian populations. Typical signs and symptoms happen to be yellow skin, facial deformities, and this is because the bones actually widen. So our facial bones get wider. They have a delay in their growth. You might notice abdominal swelling, and we'll talk about this. Actually, go ahead and talk about it. It's related to the enlarged spleen. So the spleen actually gets larger and it causes abdominal swelling. And then, of course, we have dark urine because the body's trying to kind of get rid, or is getting rid of, that excess bilirubin as well as iron. And so that's the yellowing of the skin and the dark urine. And so we have Alpha-Thalassemia and we have Beta-Thalassemia. So Alpha-Thalassemia is, of course, the alpha chain of the hemoglobin. And the symptoms are going to depend on how many mutations are inherited. And so if there's one mutation, not that big of a deal. You're considered a carrier. There's no real symptoms. Mutations 2 and 3 go to mild, moderate, and severe. And then anything 4 or over are going to result in stillbirth. So greater than 4 mutations is going to be stillborn. Or they may live, they may get through a couple of blood transfusions, but they're quickly not going to live. So either stillbirth or die very soon after birth. The next one we have to address is beta thalassemia. And beta thalassemia, of course, is the beta chain of the hemoglobin. Again, has to do with the mutations. If it's one mutation, there are very mild symptoms, and this is known as beta thalassemia minor. 2 mutations, more severe symptoms, and that's beta thalassemia major. So treatments and major complications. Oftentimes, these patients require frequent blood transfusions and or they may need stem cell transplants, okay? The problem with blood transfusions is it can actually lead to iron toxicity or iron overload. So while we were talking about iron deficiency anemia on one end, our beta thalassemia, typically major, is going to come with iron toxicity or overload. And so what can happen here is there can be too much iron that will actually damage the heart. It might cause congestive heart failure. It may damage the liver or even the endocrine system at some point. The endocrine system is found throughout the body. And so it just would depend on where it's settled as to where the endocrine disorder would be. And so this is a very specific treatment that I have seen on nursing tests, I have seen on the NCLEX, and this is called chelation therapy. So whenever you hear of somebody with too much iron, iron overload, or they have beta-thalassemia major, I want you to think of chelation therapy that's used to remove excess iron. There are several medications that run in this class, but remember, I like for you to know the top 1 to 2 medications because a nursing test is not going to ask you all the meds in a class. Okay, so I go with the heavy hitters. And the heavy hitter for this happens to be deferoxamine. So DEFEROXAMINE. That is used specifically for chelation therapy to remove excess iron. Okay, and thank you guys for hanging out with me on the anemias. If you have any questions, make sure you drop them in the chat, leave a comment, like, share, make sure you subscribe. See you in the next video.